I'm more than happy to speak to you and give some of my experience to you. And I hope that has some influence on the daily clinical practice, at least for you to may ask, do I have another idea to bring into my clinical practice? For myself, I'm now the head of department in anesthesia and intensive care in a regional hospital in Hamburg. And I've been at the university clinic in Kiel for the last 18 years, where I was the vice chair of department the last 5 years. I've done and conducted a lot of research with regard to death of anesthesia monitoring, and I'm very thankful also together with GE for a large multi-center trial that we published a couple of years ago. I'll give you some of the data that we had out of this study in a little bit. When we talk about death of anesthesia or components of anesthesia, Bernd Urban, over 20 years ago, defined, I think, this nice picture. There's something that we want to induce, and there's also on the other side that we want to avoid. And in one earlier session today, there was question what are most anesthesiologists feared about. And of course, airway management was one of the topics, but on the other side, 4 out of 5 anesthesiologists were fearing about correct amnesia and possibly awareness doing their procedures. And on the other side, also 3 out of 5 were worried about convulsions and post-operative cognitive dysfunction. So we as anesthesiologists, we always have to find the right balance for our patients. And then we have the cortical components, and we have the subcortical components, and all of that we want to measure in every individual patient. There is a workstation that you can see here that has all those monitoring techniques inside, and want to give you a complete picture. And I want to show you which is now a GE presentation, but I want to give you my insights and may help to find for you, for your patients, the right dose of anesthetics. I've shortened this slide. When I talk to my younger colleagues, I put this in different steps. But just for you, we have the anesthetic concentrations, and we have the response of our anesthetics. And of course, there is a variability in every patient, and we do have to be on the right dose. I'm not using this arrow because this is very slowly moving. So this is the green line. This is where we want to be. And the green line is set, but the concentration we need to be in the green line is depending on the stimulation intensity, for example. So this is something we experience in everyday practice. The patient waiting for the surgeon is another patient when there's maximal stimulation. And even in these situations, we have to be on the green line. When inducing our anesthesia, I like this picture because when I talk to my younger colleagues, they ask me, why do you use so much time in dosing the anesthetics? And this picture is just for you to see that if we have different induction speeds, there is something different happening in our brains, here shown by the delta ratio, beta ratio. When you have a fast induction, you see a paradoxical excitation phenomenon, which is not present when you do a slow induction. So not only the pharmaceutical, the anesthetic has different effects, also the speed of induction has an effect. And how should we know in the individual patient what is my correct speed for my patient that is in front of me? And this session, I want to put the bridge to the hemodynamic effects, because we know that side effects like mortality depends on the hemodynamic stability. So if we have hemodynamic instability, like here seeing hypotension, then this is directly associated with morbidity and mortality. So induction speed, has an influence of our patient outcome. And these are predictors for hypotension during anesthesia. These are patients that come into our anesthesia room already hypotensive. Propofol induction itself, every one of us knows. The age, the older patient makes a difference, and we have to learn a lot about that. The geriatric patient, how does the geriatric patient is being influenced by our anesthetics? Of course, also the opioids, and the sicker the patient, the more difficult it is. So how can those monitors help you in providing individualized, precise anesthesia induction? Here I have a study, high-risk patient, CABG patients, and the question was, induction, does entropy, EEG monitoring help us with regard to hemodynamic stability? So we had one group that was guided by entropy, and the other control group was using clinical judgment. Both were very slowly inducting, and what we could see is that we have much more high potential events in the group that has not been monitored. So already monitoring the patient during induction phase provides more hemodynamic stability. We had less propofol. So when we go into the clinical practice, it is really useful to already start the monitoring in front of the anesthesia procedure. And here, just an advice, if you do in the TIVA anesthesia using remifentanil and propofol, I always start the remifentanil slowly before I start the propofol, let it come to the patient, see the side effect, the effects, and then slowly inducing propofol using the entropy. How about maintaining our anesthetic procedure? Another CABG study, this was an off-pump study, similar setting. We had a study group which used entropy and a control group just our regular monitoring. And not surprising, we had less propofol, less sufentanil, and then more hemodynamic stability, less vasopressors. This giving you the information to not overdosing your anesthetics, because I think what I said earlier, 3 out of 5 anesthesiologists are worrying about cognitive dysfunction. We tend to overdose our anesthetic, and we want to be more precise and not giving one dose fitting for all. Okay, now something, we had the induction, we had maintenance. Now with regard to waking up, emergence. Similar setting again, this was thoracic surgery, and this time not TIVA, it was balanced anesthesia. On the other side, clinical judgment. And again, you see by using clinical size, you tend to overdose your anesthetics. You have a much higher percentage with your entropy values below the target zone. When you use the monitor, of course, these zones, these not being in the target zone, these overdosing effects are missing. So significant more periods with too deep anesthesia. And with regard to emergent, we have faster spontaneous eye opening when using the monitoring. And this was also surprising when you look at the data, 7% in the entropy group, 24% in the clinical group with agitation, post-operative agitation. So it does not only have an influence of your procedural things, it also has your patient safety, agitation. No one wants that in your post-anesthesia care unit, is positively influenced when using such monitoring. Faster eye opening, less agitation. Are we ourselves good enough to be in the target zone? This is an interesting study because they had one group where they did manual adjustment and another group where they had help by a computer system adjusting the anesthetic to be in the target zone. And as you would guess, the automatic dose adjustment had a much higher possibility to land in the target zone than doing manual adjustments. And that is very important because we look into the future, and I'm very positive that in the future we will use much more those automated system in bringing our patient into the target zone. I show you here an example. So optimized dosing, you see here the entropy lines. They are well in the target range. When you do non-optimized, you have periods where you overshoot, and most of the time you tend to overdose your anesthetic. But is that all? Is that all looking at entropy and hypnosis effect when we talk about our components of anesthesia or balance of anesthesia or depth of anesthesia? I think no, it isn't. Because we have the suppression to respond to noxious stimulation, also known as analgesia. And using the surgical pleth index, which I introduced to you now, is one option to get a better view of your analgesia component of anesthesia. In total, when monitoring nociception, you could do some of the cortical effects, but they are late and they are not very specific, so using the EEG for that. Most of them are subcortical, as I've shown you before, and they are mainly based on autonomic and cardiovascular sympathetic responses of our body. This index, introduced 15 years ago, uses heart frequency and pulse amplitude, which is already included in your non-invasive measurement of oximetry. So this very simple index gives you an idea about the nociception and analgesia component of anesthesia. When this was developed, the researchers, we just talked about him, Matti Hucke was the first author in this study. They looked at different different monitoring devices and said, can they put apart stimulation effects or not, doing TIVA, and they saw this, the remifentanil effect. They looked at stimulus intensity, and they came out with these simple parameters called surgical pleth index, was included the pulse amplitude, which increases when you have a cardiovascular effect and activation, and the heartbeat interval. So when this study came out and the device was set on the market, we did a proof of principle study where we had anesthesia induction. We were in the induction room, no surgical stimulation. We just looked, okay, different concentrations of remifentanil, and can the device check whether this is responding or not. So we had, as response, we saw unpurposeful movement, and our test stimulation was a tetanic stimulation, so electrical stimulation on the hand. And you see the reaction for those patients who moved due to the simulation was much higher and much more pronounced in the one that did not move, and also the activation time was much longer than those that did not move, that only showed some of the activation in a short period of time. What you also see is that your interval, okay, between the stimulation and the maximum value was very short. So it was only 20 seconds, which is important because we want to react immediately. Another very important thing is when we described that, we were often asked, why do not use just heart frequency? This is something we already have in our monitoring. So we looked at the delta, the change of heart frequency, and the delta of the surgical pleth index. And as you can see, we had none of the patients that moved that did show a delta value of the SPI less than 10. All the movers had really a peak in the delta SPI. We did not see that for the heart rate. So heart rate itself is very unspecific and may not be used as an adequate monitor for the nociceptive compartment. This study, I do not want to go in detail. They looked at regional anesthesia compared to general anesthesia and using SPI, and the authors conclude it is so advisable to invest into the SPI monitoring. So they were very convinced because they could show that the regional anesthesia in this study, they looked at eye surgery, could be avoided because the dosing of fentanyl was so precise by using the surgical pleth index. Now 2 studies I want to introduce a little bit more where the entropy and SPI were used as guidance for anesthetic. This study by Ingo Bergman from Göttingen was published 10 years ago, and he could already show that we tend to overdose anesthetics, so therefore dose reduction of remifentanil and propofol. And very interesting, and it's shown in the other studies as well, you really influence your operating processes. You have faster emergence when using those patients. These were quite healthy patient, outpatient, ambulatory anesthesia procedures. Now the earlier introduced multi-center European study, 4 university centers in Europe. We did this, and this was published in 2020, almost 500 patients. So far, the largest study regarding anesthesia monitoring that we have so far. With respect to unwanted events, intraoperatively, we could not find a difference. If anyone is interested why I think it is like this, then we can talk later on or discuss that. There are certain points because we were not able in the study to react immediately as we actually should have. But again, what we could show is the emergence was much more predictable in the group that used such monitoring. And this was not only by waking up from the anesthesia procedure, this was continuing when looking at patients at the post-anesthesia care unit, where also patients were readier to be changed and sent to the normal ward much earlier than in the control group. And this phenomenon can be shown by many, many studies that look now at monitoring. You have a much more predictable wake-up time when using those monitors. The percentage of patients that have long periods of waking up is really dropping down big time. Okay, therefore, I suggest the practical dosing issue. Use entropy monitoring and nociception monitoring, in this case surgical pleth index, to anticipate an anesthesia balance that is very important, especially when now looking at older patients. Check the patient's state whenever your entropy value goes up. So there you should check, is everything all right? Do I have a problem? Is my IV line correct when I use TIVA? Avoid overdosing and cardiovascular side effects. I could show you the more hemodynamic stability, and as conclusion also be ready to react when there's a change and you are aware that something's happening. There are meta-analysis. This is not my personal opinion. We have more data. We have opioid sparing effects shown in different meta-analysis, and it's also my experience. With respect to faster emergence, it's been shown in many, many studies. I'm very convinced that these kind of monitors help us, especially in ORs with a high throughput, to help that we have a faster recovery of the patients. I do not want to miss showing you the confounders because they're very important to know. Remind that the value of surgical pleth index is a cardiovascular response to noxious stimulation. It is not a magic bullet. Yeah? So whatever influences our cardiovascular system should be then thought over. And so it could be atrial fibrillation, high vasopressors, pacemakers, sedation, co-medication. We don't know how much dexmedetomidine, for example, influences the surgical pleth index. There is influence, we know that. The positioning of the patient, I show you a short video shortly, and also the type of anesthesia. So this is the video I introduced. Now we'll put the patient's head up, and then now you see what happens to the monitoring. Of course, then you have a cardiovascular activation, and you see the value of surgical pleth index immediately increases. So this has nothing to do with nociception. This is just cardiovascular response. Important to know, not misinterpreting those data. And we have other things, pneumoperitoneum, trocar insertion that can also do such changes. So whenever there is something happening in those values, check your patient. There may be other reasons why this is happening. Okay, then vasopressor. In Germany, we use the vasopressor Acrinor, which is a vasopressor and inotropic combined. And of course, you see after injection such a change in SPI, which has nothing to do with the actual nociception state. And this will correct shortly afterwards, so then the value is very stable. This is, in my opinion, a stability of the signal is very important. There are monitors on the market that use other activations like heart rate variability. My experience is that those values are not as stable as you see here with the surgical plus index. Okay, driving better outcome is the goal. I think monitoring by using entropy and surgical plus index helps to stabilize hemodynamics. I've shown you less opioids and faster recovery. And it at least needs a good anesthesiologist, so it needs us to be there in place. Thank you very much for your attention.